morning. I'm really glad that those of you who arrive early appreciate you every time. I want you to hear that. I'm really glad to see lots of new faces in the audience. That also makes me very happy. But I learned long ago that everybody wants to leave on time, so I try to start on time so our speakers have the opportunity to do what they need to do. As you know, we have a series of ethics lectures each year, and they are coordinated and operated by Ben Wilfont. He'll tell you how they're a little different model. Hopefully many of you have already had that experience. So Ben, Director of our Ethics Department.
Hi, thank you. For those of you who haven't been here before for one of our ethics grand rounds, we have a different format from a speaker who will give a 55-minute talk and then have 5 minutes for questions. What we have is a case presentation for about 10 minutes describing a case. These cases are based upon real cases, but they're often changed a bit to make them more generic. It's not meant as a retrospective review of an actual case, but really meant to be the jumping off point for future discussion. After the case presentation, if there's a quick question of clarification, we'll take that. We'll then we then go to a 15 or 20-minute commentary by an outside commentator. And then when you add up those numbers, we still hopefully have a good 20 to 25 minutes for discussion. Which is why we have the microphones on both sides of the room to really try to encourage people to come up to the microphones for discussion. You can form a queue if there's a lot of enthusiasm, and that helps the speaker kind of judge who to call next and the order of things. But we really see the discussion as being a big part of what's going on. The other thing I'll remind people is we hope and anticipate that people have different views, so we encourage people to express their views, but also to be respectful of the views of the people around them. We do this 3 times a year. We have grand rounds. Twice it's a case-based grand rounds like this. Once we do a more formal lecture. And we also have a summer conference. So in fact, we won't be having grand rounds in July, but for those of you who have seen it on the website, we're having our Pediatric Bioethics Summer Conference July 23rd and 24th. Sayeed, our speaker today, is actually one of the presenters at our summer conference as well. The topic there is on neonatal and prenatal care, and in fact that's part of why we chose this topic today as a way of sort of introducing that theme for our summer conference. We will be having a grand rounds in August. That'll be similar format, but this time it'll be with local presenters. Gary Walco, who is the head of the pain medicine program, will be talking about the use of placebos in clinical trials, in clinical care rather. And then in October, Tom Murray, who is the president of the Hastings Center, will be talking about drugs and sports, which that should be a very interesting conversation. So let me go on to today. The last thing I'll mention again is that before I go on to today, is that the series is actually supported by a fund created by Jeff Sconyers and Deborah Godfrey, and we're always grateful for their support of this program. So for today, we have something slightly different because our case presenter is typically a clinician who has brought an interesting case to us that we've thought about. In this case, it's an interesting clinician, but a clinician who is heavily involved with our ethics program. David Woodrum, for those of you who don't know him, came here for his residency or fellowship, was it? Fellowship in 1968 and has been here ever since then. He is a neonatologist but has worn many, many hats over the years, including until just this past year has been the chair of the ethics committee. And so David has been heavily involved with the ethics program, and we thought he would be the perfect person to present this case because it's a neonatology case in which he can have the perspective both as a clinician as well as the bioethicist. Our invited speaker is Sayeed. Saad is trained as a lawyer at the University of Michigan. He then went on to get his MD degree, and as he is currently at at Harvard in the division, and he has a very interesting position there. He is in the Department of Social Medicine, which is one of 2 departments of social medicine at medical schools in the United States. Within there's a division of medical ethics that he's part of that group. He's also a neonatologist at Boston Children's Hospital, and it's a pleasure to have him here. So at this point, I'd like to turn the podium over to David, who will present the case. And I'll get you. There you are.
Which one advances?
This one right there.
Okay.
Yeah.
Good morning, everybody. I promise to be respectful, as Ben said. This case represents one that was particularly vexing for me, and I look forward to hearing Sad shed light on this. So it involved a young 30-year-old gravid 2 mother who was at about 24 and a half weeks gestation. She presented at another hospital with ruptured amniotic membranes. The fetus was in the breech presentation. She was demonstrating clinical symptoms that were compatible with an abruption, and she was in labor, and her cervix was complete at the time that she presented. So the health providers involved in the care at that institution, in, as you might gather, a rather chaotic situation, attempted to counsel this mother and her husband, and provided them with the usual numbers that we use: 70% survival at this gestation, estimated long-term morbidity of about 25% being severe, about 25% moderate, and about half of the infants that are born and survive here have relatively normal outcomes. Given that input, the parents, according to the records, agreed to aggressive resuscitation. And I put question marks there because as one goes back and tries to sort this all out, that's not clear. The father was clearly ambivalent about this, but the mother was very concerned about the poor outcome. So she saw the glass as half empty. Both the mother and the father were well-educated professionals who were short-term residents of this area for the purposes of career development. And they planned to return to their country of origin in the near future. And this begins to identify the vexing part of all this. They indicated to the providers that in their country there were no services for individuals with handicapping conditions. In particular, females were devalued, and this was a female fetus. So as things are, when people cross our doorsteps and get on our care escalators, they proceeded to C-section delivery. The baby was 650 grams. She was immediately intubated, responded appropriately to that, stabilized on low-level ventilation and a moderate amount of oxygen, and had an X-ray compatible with the typical findings of respiratory distress. The parents at this point continued to be very concerned about long-term outcomes and morbidity and requested a transfer to the UWMC NICU. When they arrived at the NICU, they reluctantly, after counseling by the attending in charge, to continue current level of support. But they requested a discussion of any escalation of care, which was agreed to, and requested a DNR order, which was agreed to. So as I reviewed the records for the first several days of this infant's course, they're relatively positive. The quote from the attending was this infant was alert, active, breathing over the ventilator, and that it may be possible to extubate this infant to CPAP in the near future. The cranial ultrasound was normal. There was a murmur there, estimated to be a PDA, and the treatment at that point were IV fluids, nutrition, antibiotics, very low-level assisted ventilation and oxygen, and indomethacin to try and close the ductus. The infant's parents continued to be agitated, unhappy, regularly requesting withdrawal of the communicated support measures. The NICU staff across the board, from nurses, respiratory therapists, up through physicians, were not in agreement with this, and an ethics consult was requested by both parties. So the ethics consult indicated the following: assessed and found a stable clinical course, responding appropriately to standard NICU care without significant comorbidities. The prognosis for survival was very good at this time, for long-term morbidity not well established. And after discussion with the nurses and all involved in the care, there was no evidence of suffering. So the quote was, "The parents' legitimate concerns for long-term morbidity and suffering do not at this time outweigh the infant's right to receive continued care." So the recommendations were to continue current management, which meant to reject the parents' requests and ignore their ongoing concerns, to work to involve the parents in the infant's care, to keep an open mind and readdress the issue of aggressive care if the infant develops significant comorbidity, particularly if there is suffering. And the last comment was, it would be reasonable to determine if there are other NICUs in this area where the parents might be more comfortable and might be more willing to accede to their requests. And by the way, the attending, I think, made a half a dozen phone calls and could find nobody that was willing to do that. So over the next 2 weeks, the infant's radiograph changed to indicate mild chronic lung disease, and the ventilator and oxygen requirements went up a little bit. There was a persistent patent ductus arteriosus. The infant developed a gram-negative sepsis, began to have intermittent hypotensive episodes. The follow-up cranial ultrasound demonstrated mild bilateral ventriculomegaly. The abdomen was described as mildly distended with an ileus. And the attending notes, if one followed the sequence of them, indicated slow deterioration. So another ethics consult was obtained. Aren't those ethics consults helpful? When you can't think of anything else to do, get an ethics consult. So the follow-up ethics consultation noted that the prior recommendations were for continued care unless, despite the wishes of the parents, because the patient was medically stable. The patient's medical condition has since deteriorated and her prognosis has worsened. Her chance of severe disability has also increased. At this point, the majority of the NICU providers felt that she is currently suffering, her quality of life has diminished, and withdrawal support at this point would be reasonable. So the recommendations were given the parent preferences and the appearance that they're acting in the child's best interest. Said, I hope you're going to define best interest for us. Given the child's escalating level of care, increased suffering, and worsening prognosis, it would be ethically justifiable to withdraw life-sustaining treatment. And it was. So the questions here for this specific case are, should the potential for long-term disability be a reason to permit parental discretion to withdraw support? And what's the threshold beyond which the parent shouldn't be allowed to do this? Should a family's cultural beliefs or country of origin justify greater parental discretion? And does it make a difference if the family is planning to return to a country that has different cultural views or support services about pediatric care? And this case, I just might add, this case is focusing on a NICU, extreme prematurely born patient. but it represents what appears to me to be an increasing number of these cases, not just limited to the NICU. And so it sort of is a repetitive theme that we're seeing in our ethics group, where parents, for one reason or the other, sort of reject our wonderful health care advantages, organ transplants, NICU care, PICU care, etc., and prefer to, in their mind, the best interest of their child, or to not do that. So with that, turn it over to Said.
Yeah, you go. Yeah, it's going to the next one. Does anybody have quick questions for David for clarification? Yes. Actually, you meant to come to the microphone so that people out in Whammy land can hear you.
Yes. He's intubated on very low ventilator oxygen.
And people still felt that there was no suffering.
And ask if they considered giving up the child for adoption.
Dr. Shirtliff asked me to ask whether you giving up the child for adoption.
That's an option that is always mentioned to parents, and I've been offering that option and hearing it offered for, sorry to say, 40 years, and I've never seen it accepted. The parents are often always insulted. You should make the offer.
I'd like to say that if Dr. Shirtliff wants me to ask a question, I will do that. But my question was, so after the first ethics consult, one of the recommendations was that if there is another institution willing to withdraw care, we can send her there? Is that what that was?
That was an offer that was made.
Okay.
Good question.
Just want to make sure I understood that. Thank you.
Okay, thanks so much, Dr. Wilfont, for inviting me, and thanks for having me today. It's a pleasure to be here. It's been 4 years since I've been here, and it's really lovely to be back and see some familiar faces. So, this is a lovely case for somebody like me. It's also a tragic case, and it's not one that, unfortunately, David, I'm going to provide a lot of clear answers to, because I think, as we just said, if you give an answer that you say is right, you probably need to do the opposite. It's a challenging case, and so, and slideshow. Excellent. Let's see if this... My slides are not on here. I did bring my... We could just have a discussion.
No, we can fix that.
Well, no, I have my... I also have my power thing. Well, let me just... I have my notes, so while we're getting the... Because I sent you the... it's not my fault. Just want to be clear.
This is an ethics conference.
We at Harvard don't make mistakes. Please, I'm just teasing.
You actually...
I do have it, yeah.
Okay, I was so confident I'd done this right.
Here we go.
And here...
So what I'm going to do is sketch out some concerns I have about the standard analysis, and very much try to nail down what the problems I see with this idea of best interest analysis, because I think that this case demonstrates the fundamental problem with that construct. And it's one that I have made a critique of, but not everybody. I doubt it will resonate with everybody here. Something bad happened? Did you show slides of my daughters or something like that?
I did, actually.
And then I'm going to sketch an alternate framework that, again, I hope is provocative and tries to make more transparent some of the things that I think are under the surface in this case that, that David, again, alluded to, but that I think we might benefit from having. Nope, not that one. Seattle Grand Rounds. Yep, Seattle. No. That was yesterday. And there you go. Voila. So when I do ethics consults, this is how I do them. And I recommend it because I think it makes it much easier when they're hard cases. So this is an unfair question, as I said. I don't think that we can say who's got it right, but that's often how we think. We think that's what our task is. This is something that I think is really a struggle, and this is for the philosophers in the room. I mean, I think there's a deep epistemological problem here about how we ascertain what right answers are, and I'll mention that again at the end. So my objectives, I told you, were to express concern with the standard analysis, sketch an alternative framework, and acknowledge the meta-ethical problem at the end. So I think David has nicely offered us a not-so-subtle provocation when he said that the survival statistics, as we know in neonatology, are ever better and better. And this is a chart that I think the groups in Chicago published many, many years ago, but it certainly jives with what David was saying. The longer you live in a NICU, the more likely you're going to survive, right? So if you make it past the first few days, your chances are going to increase, almost exponentially that you're going to survive. So now you're talking about a 21-day or a month-old child who's really probably got a very good chance of survival, even with this current intercurrent infection. So I think I skipped a slide. Oh, no, I did. Okay. So what I want to suggest to you is that when we talked about this change of the consults and what had happened, David showed you the word slow deterioration, and I'm just going to ask the question, not expect an answer. What do we mean by slow deterioration exactly when that's written as a note? Has this baby's clinical condition or this slow deterioration substantially changed this baby's interests? And the questions I would ask as a neonatologist that I'd want to know to inform that is well, was the bug sensitive to antibiotics? Had the baby cleared the infection? Was there a follow-up culture where the infection was actually cleared so it's not something that's persistent? Have the odds of mortality dramatically changed because of this infection? I would argue probably not. If he's cleared the infection, she's cleared the infection, and how significantly have the odds of long-term morbidity changed because of this infection? I'm just not sure. I don't have data to say that there's an obvious 20% now increase in severe morbidity. Sure, we all worry about it, but what are the numbers, and do those numbers actually matter? So I think these are important questions that I think, for the purposes of provocation, we'll just say that all those things are not clear. So the standard paradigm, of course, is to act in the child's best interest. This is endorsed by our Supreme Court and common law, child health advocates. I'll just give you a quote from probably one of the more famous Supreme Court cases that sort of speaks to this. The law's concept of the family rests on a presumption that parents possess what a child lacks in maturity, experience, and capacity for judgment required for making life's difficult decisions. More importantly, historically, it has recognized that the natural bonds of affection lead parents to act in the best interests of their child. As with so many legal presumptions, experience and reality may rebut what the law accepts as a starting point. And that was Chief Justice Berger in a 1979 decision involving an adolescent. So the AAP, of course, endorses best interests, and many famous pediatric bioethicists, some who are in this room, also have endorsed it. And John Paris, who's one of the guys over in Boston who talks a lot about these kinds of cases, says this: there is now strong consensus in the medical, legal, and ethical literature that it is the best interests of the infant, not the desires of parents or the determination of the physician, that must prevail in the care of newborns. I think it sounds lovely. I just think that we need a lot of work to do to actually get what that means. So, to humor you and say, well, what do we normally think of as a calculation when somebody's doing a best interest analysis? You all know this because you think about the net balance of benefits and burdens to the child, and that can include the treatment options, what their prognosis is, what the risks and benefits and side effects of the treatment are. the nature and degree of physical pain and suffering, a word that was just used earlier, from the condition and from the treatment and without the treatment. And then, of course, quality of life and quantity of life are considerations. Now, for some people who have a more conservative bent, they would question this idea of quality of life, and I think that we have to acknowledge that as part of attention here, and I'll try to get back to that. But that's sort of the kind of thing, the metric we go through when we're trying to do a best interest analysis. What I want to suggest to you is that we have a problem of vantage and perspective. And so if I showed you this slide and said that this is the slide of a baby that we often see in the NICU after they've had a devastating intraventricular hemorrhage, and this is evolving brain injury, we might very quickly say this baby is suffering in a way that warrants a reconsideration or redirection of care. On the other hand, if I showed you this picture of the exact same child 2 years later, you'd say, you're not being fair, sad. But that is exactly who that child is. And I'm just trying to bring home the point that vantage and perspective is very hard for us neonatologists, I'm admitting this of myself, to gain an appreciation of, because we take care of them when they're small and we don't see them, not all of us see them when they're older. And I've had a long-standing discussion with our developmental pediatricians at Children's, and they have a very hard time wrapping their head around how we think about these decisions because they see these kids in a very different light. It's not always a glowing, lovely light. In fact, it oftentimes isn't. But they don't see them as that kind of brain injury anymore. Okay? So I would suggest to you that on the one hand, an incompetent newborn has no life experience to otherwise inform or evaluate the benefit of treatment versus the burden. So we're stuck. And parents, as I said, are presumed to be the best in the best position to approximate the values that they think would be most significant for their children. On the other hand, I think very few of us, parents included, can extract our own subjective perspective about which is often grounded in a sense of our normalcy from what we presume to be in a child's best interest. And I would suggest to you that most of us, or many of us, are inclined to discount the value of compromised life in these kinds of situations. So I'm just going to suggest that again, trying to be a little bit provocative. Just to build a little more support for it, most of you will know Saroj Saigal's work from Canada, and I'm not saying that her study group maps perfectly onto the population we take care of today. She probably had a lot of growth-restricted babies, but she followed a cohort of babies that were extremely low birth weight followed them for 25 years and followed their own reporting of quality of life. And this was a study, I think, in pediatrics from 2007, where in young adulthood she had them report on their quality of life. And I'll just give you a little quote from it. In the current study, extremely low birth weight young adults reported a greater burden of morbidity in several attributes, despite a greater proportion with functional limitations and complexity of deficits. A significant majority of extremely low birth weight respondents reported a relatively high quality of life at young adulthood. In fact, there was no statistical differences in the mean utility scores between the normal birth weight cohort and the extremely low birth weight cohort, and that included parental proxy responses for the 10 severely disabled, extremely low birth weight babies. So for the adults who couldn't communicate themselves, they asked the parents, and the parents said they think their quality of life is okay. So Saigal just mentions in her discussion, again reinforcing this idea, that a prevailing perception among individuals without disabilities is that good quality of life is not possible, or at least is unlikely, when serious ill health or disability is present. People with limitations in physical function are sometimes assumed to have parallel limitations in social and emotional function, making them unable to enjoy life to the fullest. And she's obviously challenging that position. A picture of some of the kids that were in her study. So if I'm trying to be a little bit provocative about how we ought to think about best interest, you might say, well, let's choose another formula. Let's figure out another way to accomplish what we want to accomplish. And here's one. Back in 1983, the President's Commission published a really lovely, actually, treatise on decisions to forego life-sustaining treatment, and I would recommend it to any of you because it's a careful study. It's not, I don't agree with everything that's said in it, but they had a chapter dedicated to seriously ill newborns, and they created this graph that may be familiar to some of you, but it sort of gives you a way to think about how to decide what to do. So you have a physician's assessment of the treatment options. You decide whether it's clearly beneficial, ambiguous, or uncertain, or futile. And based on that categorization, you can decide what you do based on what the parents want. So if the parents prefer treatment, obviously if it's clearly beneficial, you provide treatment. If the parents prefer to forego treatment, you provide treatment and you begin a review process. So this was sort of like ethics consult number 1. Now, if it's ambiguous or uncertain, you provide treatment if the parents want to have treatment, and you don't provide treatment if the parents don't want to provide treatment. This is, of course, ethics consult 2 in our case. So again, I just want to push you guys to think a little bit about what makes this case suddenly ambiguous or uncertain. I think that's a question that's worth thinking about. And then obviously futility. If you think it's futile, you provide treatment if the parents want it, unless the provider declines not to do so. And then, of course, you do what the parents want to do if they don't want to do it. So maybe this is a way out. Maybe we can use this ambiguous category, or maybe not. This is a direct quote from the chapter. This is a very strict standard in that it excludes consideration of the negative effects of an impaired child's life on other persons, including parents, siblings, and society. Although abiding by this standard may be difficult in specific cases, it is all too easy to undervalue the lives of handicapped infants. The Commission finds it imperative to counteract this by treating them no less vigorously than the healthy peers or than older children with similar handicaps would be treated. And they go on, and I think this is the part I didn't put up, but I want to read it to you because I think it's very important about perspective. The importance of adopting the viewpoint of the incompetent patient is especially well illustrated regarding newborns. For many adults, life with severe physical or mental handicap would seem so burdensome as to offer no benefits. However, this assessment largely arises from the adult's existing hopes and aspirations that would be forever unfulfilled. From the perspective of an infant who can be helped to develop realistic goals and satisfactions, such frustrations need not occur. In fact, many severely handicapped persons are quite successful in finding and creating meaningful lives despite various limitations. Adopting the infant's point of view requires valuing these successes equally with the more conventional ideal. Trying to build a case for how we should think about best interests. Here's the last 2 pieces. So Ron Dworkin, for those of you who don't know, is a relatively famous philosopher who's wrote a lovely book called Life's Dominion, and he just makes the following statement. I do not mean to deny that sometimes people would be better off dead when they are in great and terminal pain, for example, or because their lives are otherwise irremediably frustrated. But this is rarely true of children born into even very great poverty. Nor is it necessarily true even of children born with terrible, crippling handicaps who are doomed to shortly die. So I can tell you that when I give a talk like this to a group of lawyers or philosophers, they see this pretty clearly. They think that this is the right way to think about best interest. There are exceedingly few cases where if you're focused specifically on the child and they're not in terminal or intractable pain and suffering, that you can really confidently claim that it's in their best interest, that death is a better choice for them than trying to extend their life to the point where they will recover from the illness, they'll have handicaps, but they'll be able to extract some pleasure out of life. That's a very tight conception of best interest, and it's one that carries some persuasive powers. I'll just give you an example of it. In the law, which is someplace I've spent some time thinking about it, I think that you will not find you may find not as much friendliness or receptivity to a more broad or expansive notion of best interest. And this is just an example. It's a little bit of cherry picking on my part, I admit, but it is an example of the concern that a lawyer or a judge might have about this idea of different people interpreting best interest differently based on their perceptions. This determination could vary greatly based on the parent's belief. One set of parents may view a particular disability as worse than death, while another set of parents would not. Such a process not unreasonably has kaleidoscopic, unending implications. And this is from Bend's state of Wisconsin. So, I think that the concern from the perspective of policy or judiciary is that there's a problem of consistency across babies, right? That's a justice issue if you want to think about that in ethical terms. So what is this case really about? I'll try to summarize things. In my mind, it's about externalities. What do I mean by externalities? Well, I mean is it ethically permissible? What is the ethical permissibility of allowing parents to make a life-ending decision for their baby based on their perceptions about what kind of life is worth living. And the ethical permissibility of allowing parents to make a life-ending decision for their baby based on their perceptions about their own quality of life, should they have to care for their daughter in a place with minimal social supports. That's a very different set of questions than asking what's the best interest of this child. And I, for one, believe that that's informing what is going on in this case. I'm welcome to hear a disagreement. So let me give you, that should say complete, a more complete framework for analysis. And I'm just trying to bring some transparency to this. So I think it's probably more productive if we just transparently identify what values are in competition here. There's a subjective personal value that, again, in a baby we can't really get at, but the idea is this autonomy principle, right? How much moral weight do we assign to one's own autonomous preferences? Standard for somebody who's older to ask them, and it usually trumps all other considerations. It's the burdens and benefits as one perceives to themselves. We just don't have that ability in a baby because it's unknowable. But I would argue that we generally maintain a strong presumption that most lives are worth living and they're better than death. Then there are instrumental values. And again, this is something that we normally don't think about with children, but in fact I think it's something we ought to have a discussion about. As you said, these cases come more and more to our attention. How much moral weight do we assign to the perceived value of one's life to others? There's no denying that we create babies that will be children who incredibly burden families in ways that can be enriching, but in ways that can be very debilitating. And that's something that we just need to acknowledge in our practice. So again, I think it's important to openly recognize and weigh openly what the cost of these externalities are on people. And then there's this idea that I think is far more nebulous, but again, it's something that pulls us in a direction of wanting to life preserve, and that is something that Dworkin calls the intrinsic or a sacred value of life. And I'm a secular, I'm not trying to be religious, but he's trying to suggest that there is an idea that life has some intrinsic value. And the analogy he draws, as philosophers do, is to a Rembrandt painting. If a Rembrandt painting is destroyed, we feel bad about that. Now, it's just a painting, right? But we feel bad about it in a way that we wouldn't feel bad about a duplicate or somebody who's recreated a Rembrandt painting being destroyed. And he's trying to say that there's something about a baby's life that we feel is sacred or intrinsically valuable that might be lost, that we can't just throw out the door. And I'll just leave it at that, and you guys can chew on that a little bit. So there are people who would argue that there isn't anything like intrinsic value, and I talked a little bit about this yesterday, but I just want to show you two curves that suggest that maybe we ought not value newborn lives, give them any value at the beginning. And these are just what we call sort of life value curves over time, and as you can see, the curves go up logarithmically as you get more life years. And so one is by Zeke Emanuel and Govind Prasad, that was published last year in The Lancet, having to do with scarce resource allocation. The other is by Dean Jameson, and again, under the situation of scarce resource allocation. But you can see basically that at the beginning of life you get very little value, but as you get older you get more value. And Zeke's formulation, as you get older you get less value. So let me just give you the language that they use. Again, this is really, I think, discounting the idea of intrinsic value of early human biological life. But just so you heard the language, the intuition behind the concept is that an infant only gradually acquires full life potential in a stream of life years beginning at birth. That is, it is gradual. The ethical understanding of this concept is based on two judgments. One, an individual life acquires value only as it acquires self-awareness, and an individual life acquires additional value as it develops bonds with others. So I'm not saying anybody in this room as pediatric providers buys into this, but it is a popular notion in philosophy and economics. And it's something that we need to struggle with, I think, when we think about these cases. So last few slides, I just want to speak to that. If we're willing to say that intrinsic value is in play, or that people might not think about valuing a baby's life as much as we value an older child's or an adult's life, then it becomes much easier to see how instrumental value to families becomes the preeminent or most important consideration in making these decisions. And so we did a study that we published last year that was just essentially a qualitative prospective study following babies born into an Indian neonatal unit, a very, very good, one of the best in India, and asked the providers how they approached end-of-life decision-making. And I'm just going to share with you some of the quotes that they shared with us. In the department, we feel that we should only give productive children to the family. No handicap, no treatment, tone abnormality, retinopathy, learning disability, need of be taken care of in special ways. That doesn't make sense. If you give a diseased child, a compromised child, the family is devastated. These are really actually very thoughtful doctors. I don't want you to think that they're callous. They're just working in a very different situation than we are. Okay? As there is no social security system for these premature and the commitment from the family is not there in our society, we try to limit ourselves to the babies where it is likely to get better. Over the child's rights are the child's belongings. The child belongs to the family. There, the family's motivation is the main factor we put weight on. Therefore, we sometimes pay more attention to the family than the child itself. We try to not make waste for a family. It is better for them to go for a new baby. So, I can guarantee you that this perspective is what is informing this family's decision and how they approach this idea, whether you call it best interest or not. This is the kind of culture that they came from, and this is the perception and the way they view the world. It's a very hard thing to say, you just got it completely wrong. I mean, this is how they have been brought up to think about the value of newborn life and life with disability, life with a female child with disability. John Lantos, who I'm sure some of you know, actually had a nice, very short piece in Hastings Center Report a couple of years ago where he went to India and gave a grand rounds lecture, and he had an exchange with the head of the department at this hospital, and I'll just share this quote with you. The other doctor, the head of pediatrics at the Delhi hospital, said this: "In America, you sometimes force treatment on babies even if parents don't want it," he said. "That would never happen here." "Really?" John said. "You mean that if a baby had an easily treatable condition but parents wanted to take him home, you'd let them?" The other doctor says, "Of course. We don't have enough resources to treat the babies of parents who want them treated. Why would we waste them on babies whose parents who don't want treatment?" In Delhi, death didn't seem as unexpected or tragic as it did in America. It was everywhere, it happened, it was part of the cycle. In the face of this, I understood the uselessness of the framework we've erected to protect the best interests of the child against even his parents. That was John's conclusion after his visit there. So, again, I just want to offer a framework to have a discussion, and I think that what I think is relevant and useful is to identify the range of consequences, both measurable now and potentially measurable in the future, to all the relevant stakeholders. So obviously there's the child, but there's the parents, there are the providers, less so. There's public perception, and there's society and the community that the child is ultimately going to go back to and that the family is going to go back to. I think this forces us to have a much harder and open discussion about which trade-offs are permissible given the uncertainty and ambiguity in any context. Some of these consequences are potentially not measurable. But we talked a little bit yesterday about expressive consequences. Well, what kind of expressivist ramifications are there if we go about letting families make these kinds of decisions in this country, allowing them to selectively discriminate against babies who are destined to be disabled and handicapped? I don't know how to measure the downstream consequences of that, but I think it's worth thinking about those things. Just as I think it's worth thinking about what we're actually going to do to this family if we keep this baby alive. They don't choose the adoption option, because I personally think that the adoption option is incredibly heavy-handed. I'm not saying that we can't talk about it, but it's coercive in a way, at least in my opinion. If you really want to champion the child's rights against everything else, then that's the option we have, unfortunately. But it leaves a lot of ugly moral remainder as far as I'm concerned. So any way you cut this, there's going to be a serious moral trade-off. And that's why I say it's not something that lends itself to a clear, crisp answer. So my last slide is just about the meta-ethical. I think that there was a lovely book. Let me just tell you that Loretta Copeland, another pediatric bioethicist, actually had a case just like this, and these are the only two things I was able to get from the literature, talking about a case very much like the one you had today. And she actually comes down, I think, sort of oddly, personally, on saying that we should definitely take care of a baby in this situation, because at the end of the day, the baby is a U.S. citizen, and we need to treat it as if it is one of our own. And so if the parents can't deal with that, they should choose the adoption option. But we need to act in this child's best interest, and the cultural values of the family don't map well onto this situation. It's more sophisticated than that, but that's the bottom line for her. I'm a little less comfortable with that for the reasons I've said. I don't know. I won't tell you ultimately how I would come down on this. But I do think that there's a challenge for us, again, epistemologically and metaethically, to say, well, what is the point of moral? I mean, are morals relative, or are there objective things that we can extract? And this book it was written a few years back by Gilbert Harmon and Judy Thompson, both really first-rate philosophers back on the East Coast, MIT and Princeton, and they had a debate about whether morals are really relative or whether they're objectivity. And I just want to quote from Gilbert, because he really draws what I think is a nice analogy about the idea of moral relativity. Motion is a relative matter. Motion is always relative to a choice of spatiotemporal framework. Something that is moving in relation to one spatiotemporal framework can be at rest in relation to another, and no spatiotemporal framework can be singled out as the one and only framework that captures the truth about whether something is in motion. I make a similar claim about moral right and wrong. I argue that moral right and wrong, good and bad, justice and injustice, virtue and vice, are always relative to a choice of moral framework. What is morally right in relation to one moral framework can be morally wrong in relation to a different moral framework. And no moral framework is objectively privileged as the one true morality. So it's a very deep thing to end on, but I think that that's part of the discussion that is actually at the base of this. And unless we are all in agreement about whether there's moral relativity or moral universality, we're probably not going to have consensus in this room about what the best thing for this baby was. So I'll stop there.
So we have time for questions. Just make your way to the microphones, and Sad, you can just sort of moderate your speakers.
Not to be greedy, but I have to ask another question. So let's imagine that it's 1950, it's 60 years ago, and we're in Chicago, and it's a black baby born with some similar circumstances. Obviously, it would be much different because neonatology would be much different. And the parents say, well, I don't want to take a disabled black baby back down to Mississippi where we live. We just happen to be visiting here on vacation to see our relatives. Is that different? And if it is, how? And if it's not, I don't know what the right answer in this, but I find this really hard. Anyway, but to me that seems to be very similar when you're talking about societal perspectives. Because in that case, I don't think there's a relativism. If you're saying that somebody is not worthwhile because they're a girl, or because their skin is a different color than yours, I don't think there's a relativism there. And if we do, then we're really in trouble. But anyway, that's my opinion.
No, I think that's an absolute. I mean, I think there's a close analogy there, and I think that people might want to make more out of the national boundary distinction we could have a long discussion about that because the idea of the justice for this baby or what's best for this baby having to do with where it sits in the world is a complicated thing to sort out. So I would say that that's a nice analogy. And all the worries that you raise, I'm worried about too. I think that there are potentially very serious, larger ripple effect sort of negative consequences if we allow this kind of activity to happen. On the other hand, I don't think that we should just say that there's nothing that we're doing to this family that isn't of significant consequence, too. We need to acknowledge that if we do this, and the only option is either adoption or just leaving the child with them without a social safety network, that's a huge price that we're extracting for the good we're trying to champion. You recognize that, right?
Yeah, I would agree with that.
Yeah.
There was a great article in Pediatrics in 1991 or two by a former neonatology fellow at Stanford who described, and I think he was a fellow in 1980, how a family begged him, literally, they practically got on their knees and begged him to stop taking care of their kids because it was killing their family.
Right.
I declare that I'm a relativist, but I don't have any solutions to this perpetual dilemma. But as Dave Woodrum pointed out, there's an increased number of such tiny babies that are going to require care. In 1983, we published our first article showing that the outcome of small babies, preterm, low birth weight babies, females, were at increased risk for repeating such outcomes. And since 1983, we and a number of others have continued to provide good evidence that that is the case. So in a real sense, it's the perinatologists and the neonatologists who have created the problem and are increasing the problem. I don't know what the answer to that is. And yeah, well,
I thought you liked me.
Personally, I do.
I thought it was bad at Harvard. This is great.
And I just want to offer a very extreme example.
Yeah, please.
Of this. A number of years ago, I received a phone call from a pediatrician in some town in Idaho, and there was an anencephalic baby born, and in spite of the physician's objections, the nurses insisted on bag breathing this baby, and this went on at this time for 3 days, and I was asked to either come and provide some ethical considerations or to send someone else. Well, I wasn't able to come. I'm not an ethicist, but I did find one to send, and I guess either the baby died or they stopped bag breathing.
I grew up to be an ethicist.
I'm not repeating that? Okay. Okay. Very good. Sir.
This is a precious institution. I just want to sort of add a framework, which is the challenge to all of us in tertiary care, that there are many children that are not getting the ethical consultation, and I'm very proud of the American Academy of Pediatrics and others that are standing up for universal protection of children. But we are making societal choices at the same time we are making individual choices, and to sort of add that frame of reference that when we're saving a severely ill infant, we may be cutting out the resources for taking care of many, many healthy children who otherwise die.
Yeah, and we had Ryan, I don't know if he's here, but we talked about this briefly yesterday, and what's striking to me is that think about the fact that we're having a huge discussion about this one particular baby right here that's driving all of us, creating all this moral angst for us. The fact of the matter is, in India, this happens thousands of times a day. I can promise you that. All across the country, babies are died who would have great outcomes, and that's just part of life. And it's a resource issue, but it's also now part of the way. I mean, they haven't had an opportunity to champion children's rights right when they're born at 24 weeks as the way we have. So it's a very interesting dichotomy that way. So I think you're right about the frame. Yes?
Hi, I was wondering if you could comment on any studies that compare the incidence of abuse and neglect in these kids versus those who are not.
Well, they're not huge studies, but certainly there are plenty of good small studies that document that the disabled, and I can say this anecdotally, I mean the disabled and females in India, children, fare far worse in terms of access to any kind of social good or communal good. Not across the board, but there's definitely a very large phenomenon that's the case. So I don't think that the parents their worries are very real about how this child would do if she was both handicapped. Forget just being a girl. Yeah, it's like a double whammy.
Glad to be too tall to use this microphone. I also find this very troubling, and so I want to preface this comment by that, but I have a philosophical question, I guess, that I'm asking myself and everyone else, and that is, what changes between a first and second generation fetus that we would allow to be electively aborted, or a 24-and-a-half-week-old baby who's about to be born and we would allow not to be resuscitated, and that same baby on the next day of life who has no more insight into the concept of future for self, that we then have trouble allowing the same decision?
Well, it's a great question, and it's the natural sort of extension of actually, Dworkin's book is about abortion. It's not about children who are born. And he makes that very point. I mean, he says it's a mistake to think that a fetus, whatever we think of its self-awareness or lack of self-awareness, if we're going to attribute interest to it, it clearly never has an interest in being aborted, unless, again, you can say that the life is going to be intractably, terminal and full of pain and suffering. And so there is this very pragmatic sort of thing that we have called birth that makes it easier for us to come in and do something like champion, separate individuals, right? Both in law and in ethics. The other thing that makes abortion a little bit different is the fact that you have a pregnant woman, right? And Judy Thompson offers a lovely analogy that doesn't resonate with everybody, but it's that there's no duty to rescue if it means doing something to yourself. You don't have to sacrifice your own body. In general, people think this, not everybody, but you don't have to sacrifice your own body to save somebody else, and that's the rough analog with abortion, right? A woman doesn't have to sacrifice her own health to be able to save a child.
So I'm going to switch from being moderator to being a questioner for one last question for you. And really it comes back to this last slide, and it's really a comment to see what your response is. It strikes me that I really enjoyed the quotes from the doctors in India. I thought that was a very useful thing. But it occurs to me that those can be accommodated without making a claim of moral relativism. Okay? In other words, you can still, I have trouble with the concept of moral relativism being taken too strongly. And it seems there's a potentially a middle road of multiculturalism, of accepting resource constraints that could still allow one to accommodate a wide range of views without claiming, well, there is no moral objectivity. So I'm just curious to see how you actually yourself come down on that specific
So I'm inclined to think that that's probably right. I mean, what I'd like to believe and what I'd like to think is that if a place like India had the resources that we had, then their moral compass would map far more like ours eventually. The things that we've done here would come. But I mean, that's guesswork, right? I mean, I'd like to think that there's this sociological, economic evolution and that morals. But that also says something about the fragility. I mean, that relativism ends up being very powerful, right? It means that until you've actually gotten that, you have to sort of respect the moral framework that a different culture has, because they don't have the ability to see the world, and approach it the same way we do. Is that? Yeah.
Unfortunately, we are out of we're out of time now. So I want to thank Sad and David, and thank you all for your attention today.